Hi everyone, my name is Krushi Patel and I'm a fourth year medical student at Rutgers Robert Johnson Medical School. In this video, I will be reviewing the clinical presentation of common peripheral nerve injuries. This video is rated MS for medical students due to basic concepts, clear language, and case-based examples. Medical student participation is advised. We do not have any relevant financial conflicts to disclose. As always, the cases presented in this talk were modified for teaching purposes. Concepts presented in this video are intentionally simplified to help learning, so we apologize to our neuroanatomy colleagues ahead of time. Finally, we often rely on the sensory maps to localize lesions in the peripheral nervous system. But remember, there is significant variability and overlap between those sensory distributions. Illustrations with pretty colors and sharp borders are nice, but the deficits in the real world are not so perfect. We begin with the case of a person with weakness and numbness of the arm. To localize the lesion, we first need to understand the nerves that make the arm work. That means reviewing the motor and sensory functions of the 5 major nerves of the arm: the ulnar, median, musculocutaneous, radial, and axillary nerves. We'll look at what these nerves do and where and how they most commonly get injured. Now, I should warn you, as we start talking about these nerves, I will have to bring up the brachial plexus. Of course, not all numbness and weakness comes from nerve injuries. Sometimes the problem starts more proximally, right at the nerve root. So, we'll need to learn how to tell the difference between a peripheral nerve lesion and a radiculopathy, specifically to distinguish ulnar neuropathy from C8 radiculopathy, median neuropathy from C6 radiculopathy, and radial neuropathy from C7 radiculopathy. We'll wrap up the upper limb section with a brief look at injuries to the upper and lower parts of the brachial plexus. Oh no, I said brachial plexus again. Sorry, I promise we'll work through it slowly, and by the end, you might not even hate it anymore. Then we'll move on to the second half of our journey, starting with another case, this time involving the leg. That means shifting gears to the lumbar plexus. Here, we'll review the 3 major nerves of the leg: the femoral nerve, the obturator nerve, and the sciatic nerve. And since the sciatic nerve splits, we'll also cover its 2 branches, the tibial and common fibular nerves. Next, we'll focus on how to separate nerve lesions from nerve root lesions. We'll walk through how to tell obturator neuropathy from L2, L3 radiculopathy, femoral neuropathy from L4 radiculopathy, and common fibular neuropathy from L5 radiculopathy. And once we build that foundation, we'll return to our case, put all the pieces together, and make the diagnosis. So let's begin with our first case. We have a 59-year-old woman with a past medical history of left-sided breast cancer, which was treated with lumpectomy, chemotherapy, and radiation. She presents with left upper extremity numbness, tingling, and weakness that started after a radiation session. Over several months, the pain and sensation of tightness improved, but the weakness progressed. She started having difficulty lifting her left arm overhead and making a fist with her left hand. Our patient also complained of hypersensitivity to light touch in her entire left arm. Touching the skin brought on uncomfortable, electric shock-like sensations. The symptoms have been going on for several months. We performed a careful neurological examination. Mental status and cranial nerves are normal. Muscle bulk and tone were normal, without atrophy. Motor testing revealed weakness in the arm abduction, forearm flexion and extension, wrist extension, finger flexion, and thumb adduction. We measured the strength as 4 out of 5, which means she was able to provide moderate resistance with those muscles. The rest of her motor examination was normal. Sensation was diminished to pinprick over the left medial forearm, predominantly medial palm, and medial dorsum of the left hand. Reflexes were 1+ on the left biceps, triceps, and brachioradialis, and 2+ in the right arm and throughout the rest of the body. Before we dive into the peripheral innervation of the arm, it pays to take a broad perspective on this case. This is a case of weakness and numbness of one limb. What are the localization possibilities? Weakness first. Weakness in one limb may be caused by a small lesion in the contralateral frontal lobe and the nearby white matter. The arm is represented in the lateral frontal lobe. In this case, weakness would be caused by an upper motor neuron lesion. The other possibility is a lower motor neuron lesion, a lesion of the cervical roots, plexus, or nerves. The universe and examinations love to challenge you with such problems because the two types of lesions have completely different pathological differentials. Now, what about sensory loss in the arm? Here we're talking about crude touch and pinprick mediated by the spinothalamic pathway, a deficit that a patient is likely to notice, as opposed to loss of vibration sense. Here too, the lesion may be central in the lateral parietal lobe or peripheral in the cervical roots, plexus, or nerves of the arm. When weakness and numbness are present in the same limb, spinal cord becomes less likely. Why? Because the corticospinal tract is ipsilateral and spinothalamic tract decussates immediately in the cord. So patients tend to get cross signs. Ipsilateral arm will be weak and contralateral arm will be numb to pain and temperature sense. Anyway, hopefully I convinced you that in our case, the lesion is either in the lateral frontoparietal lesion or the ipsilateral cervical roots, plexus, or nerves of the arm. So which is it? Right. It has to be a peripheral lesion because there are signs of lower motor neuron dysfunction, decreased reflexes, and dermatomal distribution of sensory loss. To understand what may be going on with our patient, let's first review the innervation of upper extremities. You know this was coming. The dreaded brachial plexus. Listen, it hurts me just as much as it hurts you. It begins with the 5 roots: C5, C6, C7, C8, and T1. And it ends with 5 major nerves: musculocutaneous, axillary, radial, median, and ulnar. 5 roots give rise to 3 trunks: the upper trunk, the middle trunk, and the lower trunk. The 3 trunks then split into 2 divisions. The anterior division controls the flexor muscles and becomes lateral and medial cords. These cords terminate in the musculocutaneous, median, and ulnar nerves. The posterior division that supplies extensor muscles becomes a posterior cord and supplies 2 nerves, axillary and radial. Let's start with the ulnar nerve. The ulnar nerve originates from the lower trunk and medial cord of the brachial plexus. It's derived from C8 to T1 roots. In the forearm, the ulnar nerve innervates 2 major muscles. Flexor carpi ulnaris is a muscle that flexes and adducts the wrist. The hand moves towards the side of the pinky. Medial portion of the flexor digitorum profundus is responsible for the flexion of the 4th and 5th digits. In the hand, the adductor pollicis adducts the thumb, moves the thumb toward the palm or the index finger within the plane of the hand.
You put your thumbs in between the piece of paper like this, and I'm gonna pull. So you're gonna just try to resist me pulling you and keeping the thumbs tight. Pull and bend it up. Okay, so that is a positive Frohman sign, which means the thumb adductor is weak, which is ulnar innervated. So the thumb flexor is kicking in to keep the position in place. That's a positive Frohman sign.
Hypothenar muscles abduct and flex the pinky, allowing it to oppose the thumb. Interossei bring the fingers together and spread them apart.
Now you're going to instruct the patient to keep their fingers apart and brace at the hand. So I'm using my interossei strength against hers. Notice that I'm not doing this maneuver, which is my finger flexors against her interossei muscle. It's very easy to overcome the interossei like this. You want to use your finger abductors against theirs. If you wanted to do the adductor digiti minimi, you could also do that here on the side.
Finally, the 2 lumbricals innervated by the ulnar nerve, bend the ring and little fingers at the knuckles while keeping the middle and distal joints straight. What does all this look like in the real world? The next time you're at a computer and go to use the mouse, look at your hands. Your pinky and ring finger flex with the medial flexor digitorum profundus in the forearm. The thumb adducts with the adductor pollicis to grasp the side of the mouse, and the wrist moves the mouse out to the right with the flexor carpi ulnaris. When typing, you might notice that you constantly spread your fingers apart and bring them together to reach the keys of the keyboard. Interossei help you do that. And I am pressing the Enter key here by flexing the pinky at the knuckle while keeping it straight. That's the fifth lumbrical at work. Also, for fun, flex the ring and pinky finger, adduct your thumb, and abduct your index finger. May the ulnar nerve bring you peace. The sensory innervation of the ulnar nerve includes the hypothenar eminence, dorsal and palmar ulnar region of the hand, little finger, and ulnar half of the ring finger. So what are the possible ways things can go wrong? The most common location of ulnar nerve damage is at the elbow, in the cubital tunnel.
I first start an exam for ulnar neuropathy by palpating in the medial epicondyle area to see if they have any pain or discomfort. We can look for a Tinel sign.
Now we can talk about ulnar compression from prolonged leaning with the elbow on a hard surface, or distal elbow fractures, or arm positioning during hemodialysis in patients with end-stage renal disease, or fancy rare situations where the nerve is compressed in the cubital tunnel by the thickened flexor carpi ulnaris tendon. But you don't have to go that far. Keep your elbows flexed holding a smartphone for hours every day, and you may get cell phone elbow. Is that a real thing, or did I make it up? Do a PubMed search and see. Lesions at the cubital tunnel usually start with medial elbow or forearm pain and sensory symptoms in the ulnar distribution. Over time, patients start to lose motor function. Flexion of fourth and fifth fingers, abduction and adduction of your fingers, thumb adduction, and opposition of thumb and pinky. They will complain of grip weakness and loss of dexterity when writing or typing. In severe chronic cases, patients may develop hand atrophy and the ulnar claw hand. Basically, the lumbricals atrophy and the last two fingers can no longer be straightened.
In an ulnar neuropathy, if it's severe enough, there will be, atrophy of the first dorsal interossei muscle, which is the easiest to appreciate. You might also see atrophy in the other muscles.
Ulnar nerve lesions at the wrist are less common. The ulnar nerve can be entrapped, compressed by a ganglion cyst, or injured by direct trauma. Here you may be injuring some distal branches of the nerve, so patients won't have the perfect ulnar distribution sensory loss. Motor deficits will be more obvious. I'm talking about the weakness in interossei and hypothenar muscles. But the flexor carpi ulnaris, ulnar flexion of the wrist, and flexor digitorum profundus, flexion of the last two digits, will be spared. Next, the median nerve. The median nerve receives supply from the lateral and medial cords of the brachial plexus, which means C6 to T1 nerve roots. Impulses from the C5 nerve root don't make it as far as the median nerve, so C5 doesn't contribute much to median nerve innervation. In the forearm, the median nerve innervates the pronator teres muscle, which pronates, twists the forearm so that the palm faces the floor. It also innervates flexor carpi radialis muscle, which is important for flexion of the wrist towards the thumb side. You would think that with radialis in the name, this muscle would be somehow connected to the radial nerve, but no. Radialis here refers to radial deviation of the wrist, movement of the wrist towards the side of the thumb. Moving down the arm, median nerve innervates pronator quadratus. This is the primary pronator of the forearm, stronger even than the pronator teres. Median nerve also innervates the flexor digitorum profundus. Wait a second. Why does that sound familiar? Oh yeah, the ulnar nerve innervated the medial half of this muscle. The ulnar nerve controls flexion of the fourth and fifth digits, and median nerve controls flexion of the second and third digits. In the hand, the median nerve controls the thenar muscles. These muscles flex the thumb, moving it across the palm to touch other fingers. This is crucial to accomplish the pincer grasp. Thenar muscles also perform a somewhat opposite action of abducting the thumb, moving it away from the palm.
The abductor pollicis brevis, which is this very lateral muscle in the thenar eminence. In an advanced median neuropathy, you will see atrophy of the abductor pollicis brevis. To check abductor pollicis brevis strength, you're going to have the patient extend their thumb up, and then you're going to push on the lateral side of the thumb. You can also check opponents with the thumb and pinky finger and resist.
Just like the ulnar nerve, the median nerve also innervates the lumbricals. Except, the median nerve is in charge of bending the index and middle fingers at the knuckles, while the ulnar nerve accomplishes this function in the ring and pinky fingers. What does all this mean in the real world? Want to taste that delicious chip? Use your median nerve to grab the chip by pronating your forearm and pincer grasping it with your thumb and second and third fingers. Then radial flex your wrist to face your mouth, and you're halfway there. Yeah, I said radial flex. It's a thing. You won't starve, and you have your median nerve to thank for that, at least in part. To actually get the food to your mouth, you need to flex your elbow, which is accomplished by the musculocutaneous nerve, but more on that in a bit. The flexor digitorum profundus and lumbricals flex the first two fingers, allowing you to scroll on your phone screen. The finger extension is accomplished by the radial nerve, but more on that later. The median nerve also provides sensory information from the hand through its branches. On the palmar side, it innervates the thumb, the second and third digits, half of the fourth digit, and the thenar eminence. On the dorsum of the hand, it innervates the distal tips of the first three fingers and lateral part of the fourth finger. Now that we have a better understanding of the functions of the median nerve, let's discuss possible injuries. The most common median nerve injury, and the most common entrapment neuropathy in general, is the carpal tunnel syndrome. The median nerve is compressed between the carpal bones and the transverse carpal ligament. It's caused by repetitive stress injury, repetitive forceful grasping or pinching, awkward positioning of the wrists, or use of vibrating tools. So think about occupations in which individuals may perform these activities: hairdressers, meat packers, dental hygienists, musicians, butchers, cyclists, or wheelchair athletes. But anything that can narrow the canal can result in injury. Deformation of the joints in rheumatoid arthritis, fluid retention in pregnancy, myxedema and connective tissue changes with hypothyroidism, etc., etc. Patients are complaining of sensory symptoms, paresthesias or numbness in thumb, index, middle fingers, and the radial half of the ring finger. You're probably wondering, wait Kushi, I think you forgot about the sensation over the thenar and proximal radial palm. I'm glad you're paying attention, and that is a great question. But the thenar eminence and the palm are actually innervated by the palmar cutaneous branch of the median nerve. This branch does not pass through the carpal tunnel. Patients also get neuropathic pain that radiates up the arm. The symptoms tend to worsen during sleep when unintended wrist flexion can worsen compression. The longer the nerve stays compressed, the higher the chance for motor deficits to develop over time. What are the motor deficits? Thenar muscles atrophy, making it hard for people to grip and hold objects with their thumb and the second and third fingers. When you see such a patient in clinic, how do you establish the diagnosis? Right. You reproduce the symptoms of compression by causing compression. Barbaric, I know. What are the two maneuvers you could do? The Tinel and Phelan sign. Phelan sign involves having the patient flex their wrist to 90 degrees for 30 to 60 seconds. Phelan is a sensitive test, but the specificity could be as low as 50%, so it frequently yields false positives. Tinel sign involves tapping over the median nerve at the wrist, over the carpal tunnel, to see if it elicits paresthesia in the distribution of the median nerve. Tinel has poor sensitivity, as low as 25%, but is highly specific for carpal tunnel syndrome. Compression of the median nerve at the elbow may be caused by tumors, thick ligaments, or even vascular catheterization procedures. As you can imagine, all functions of the median nerve will be affected. Radial flexion of the wrist, forearm pronation, flexion of the thumb, index, and middle fingers, and the sensory changes affecting the entire median sensory distribution. Elbow and the wrist are not the only places that the median nerve can get compressed or injured. In the forearm, anterior interosseous branch of the median nerve may be damaged by antecubital fossa fractures, strenuous exercise, even venipuncture when drawing blood. This branch is purely motor and controls flexion of the thumb, flexor pollicis longus, the tips of the index and middle fingers, flexor digitorum profundus, and pronation of the forearm, pronator quadratus. So when you ask a patient to touch the tip of their thumb to the tip of their index finger, as if telling you they're doing okay, they will instead look like they are trying to pinch something because their distal index finger and thumb cannot flex. Will you see any sensory symptoms in the hand? Nope, because this branch is purely motor. Median neuropathy without the classical sensory signs of median neuropathy. Sneaky, sneaky lesion. Musculocutaneous nerve is next. The musculocutaneous nerve is supplied by the lateral cord of the brachial plexus, C5, C6, and C7 nerve roots. Musculocutaneous nerve is fairly straightforward. It innervates the brachialis and the biceps muscles. Brachialis is the primary elbow flexor. Biceps is the most powerful supinator of the arm. It also flexes the elbow, especially after the elbow is already bent halfway. Remember how I said that the median nerve helps you grab food with the thumb, second, and third fingers and flex your wrists to face your mouth? The musculocutaneous nerve flexes the elbow and actually delivers that food to your mouth. Musculocutaneous nerve gives rise to a sensory nerve called the lateral cutaneous nerve. It provides sensation to the lateral forearm, both anterior and posterior surfaces, from elbow to the wrist. If you had to take a wild guess, what could be the mechanism of injury for the musculocutaneous nerve? Yes, fractures and neoplasms of the proximal humerus or shoulder dislocations would do it, but also weightlifting. On those days when you get a sudden motivation to hit the gym and you head straight to the dumbbells, it's the musculocutaneous nerve that helps with those bicep curls. But be careful. You overdo it, and the musculocutaneous nerve can get compressed by hypertrophy of the very muscle it innervates. And the functions impaired? Flexion and supination of the forearm, and sensation of the lateral forearm. Moving on to the radial nerve. The radial nerve is the largest nerve in the arm and comes from the posterior cord of the brachial plexus, C5 through C8 nerve roots. T1 doesn't quite make it, so it doesn't contribute much here. At and above the shoulder, radial nerve innervates the triceps and brachioradialis. The triceps extends the elbow, straightening the arm. The long head helps extend the shoulder and keeps the humeral head stable, especially when the arm is lifted. Brachioradialis assists in elbow flexion? Wait, what? Well, that seems counterproductive. The same nerve innervates an elbow extender and an elbow flexor? Well, yes. What can I say? Blame the embryological development of the posterior arm compartment. Brachioradialis is actually the weakest flexor, so it's primarily used for elbow stabilization. The real elbow flexors, biceps and brachialis, are innervated by the musculocutaneous nerve.
There are two different ways to check for tricep strength. You can have the patient in this position and then instruct them to push their forearm into your hand. You can also, and this is actually an easier way when they do have some weakness, is to have them turn their arm so the elbow's up at the shoulder, and then try to straighten the arm out against resistance. The brachial radialis muscle can also be checked. To check this muscle, you have the patient keep their hand in between a position of pronation and supination, and they need to flex their forearm up, and you can feel for the muscle on the lateral side of the hands.
In the forearm, the radial nerve controls extensor carpi radialis muscles. These muscles extend the wrist and move it out towards the thumb. The supinator muscle turns the palm of the hand upward. A good way to remember that is, how would you carry a bowl of soup? Right, you supinate your hands. Supinate your soup, people. Supinate your soup.
Check for wrist extensors by having them push up. And then for finger extensors, which are also supplied by the radial nerve, again, you can have the fingers come up and try to have the patient resist.
Finally, the radial nerve innervates extensors of the fingers. Extensor indicis extends the index finger. Extensor digitorum performs this function for the second through fifth fingers, and extensor pollicis muscles extend the thumb. Have you ever wondered why humans need two nerves, median and ulnar, for hand and finger flexion, but only one, radial nerve, for extension? We rely on flexion for most of our daily tasks, gripping, grasping, and manipulating objects. Extensors just stabilize the hand and release objects, a far simpler movement. How do you visualize the motor functions of the radial nerve? Let's say you want to push open a door. You say to your radial nerve, I really wish I could be on the other side of this door. The radial nerve says,
Please allow me, madame. Don't trouble yourself.
It then extends the wrist with extensor carpi radialis muscles and extends the fingers with the extensor digitorum, extensor indicis, and extensor pollicis muscles. And then it pushes open the door by activating the triceps. By the way, in case you are wondering, yes, the radial nerve raises the middle finger. Think about reaching out to grab your water bottle right in front of you. Raise your arm, extend and abduct your thumb, and slightly extend your wrist to grab the bottle. The sensory distribution of the radial nerve includes posterior arm above and below the elbow, mediated by the posterior cutaneous branch, the radial thumb side of the dorsal hand, and dorsal surface of the thumb, index, and middle fingers. The fingertips are actually innervated by the median and not the radial nerve. Remember that the innervation of the palm is basically split between ulnar and median nerves. There is barely any radial innervation of the palm, basically just the lateral thumb. Now that we understand the radial nerve, it's time to review lesions. We will start in the axilla, close to the posterior cord of the brachial plexus. Crutches, shoulder dislocation, arm positioning during surgeries can compress the radial nerve here. What are the symptoms? Right. Patients develop a wrist drop because the radial nerve is responsible for extending the wrist and fingers. The hand hangs in flexion because flexor carpi radialis doesn't work. The extensor digitorum, extensor pollicis, and extensor indicis muscles are weak, making it difficult to extend the fingers at the knuckles. Oh, and the thumb cannot extend. The patients won't be able to make a thumbs up sign. Extension of the elbow is weak because triceps is also innervated by the radial nerve, and the triceps reflex will be diminished. If you examine these patients in their current wrist position, finger spreading may seem weak. Wait a minute, isn't finger abduction mediated by the ulnar nerve? But spreading the fingers apart requires the wrist to be extended. In this case, you would have to passively extend the wrist to confirm that the interossei are strong. With radial palsy, the supinator muscles are weakened, making it hard for patients to turn their palms upward. When it comes to sensation, there are paresthesias and sensory loss in the radial distribution, the entire extensor surface of the arm and forearm, and on the back of the hand and dorsum of the first four fingers. Another common location for radial nerve injury is the spiral groove of the humerus. Here, the radial nerve is vulnerable to injury from humeral fracture or prolonged compression by something as mundane as falling asleep with an arm draped over a hard chair back. This is called Saturday night palsy. People fall into deep sleep after a night of partying. Just like with the axillary lesions, wrist and finger extension and supination will be weak, but the triceps muscles and the triceps reflex may be spared, since the branches to this muscle are proximal to the humeral groove. There may be sensory loss in the lateral arm, posterior forearm, and back of the radial aspect of the hand and digits. Finally, the axillary nerve. Just like the radial nerve, the axillary nerve is supplied by the posterior cord of the brachial plexus. But unlike the radial nerve, the axillary nerve is only supplied by the C5 and C6 nerve roots. This picture looks familiar. Yeah, it's the same image I used for the radial nerve. Here, the axillary nerve ducts under the humeral head and branches laterally to innervate the deltoid. The deltoid is the main muscle for shoulder abduction, especially when the arm is moved away from the body beyond 15 degrees of abduction. You need this nerve to lift your arms to the side. Axillary nerve also has a sensory branch, the superior lateral cutaneous nerve. That branch innervates the upper lateral arm over the deltoid muscle. Simple. How can the axillary nerve be injured? The axillary nerve wraps around the lateral aspect of the humerus in a vulnerable position. It is also closely tethered to the deltoid muscle near the shoulder, making it particularly susceptible to traction injuries. Imagine a patient sleeping in a prone position with the arm raised above the head, such as during a laparotomy surgery where the forearm is elevated to improve abdominal exposure. This position can stretch and injure the axillary nerve. What else can damage the nerve? How about fractures or dislocations of the proximal humerus? What muscles will be weak? Right, the deltoid. A patient with axillary nerve injury will struggle to lift their arm to the side, especially beyond 15 degrees. Will there be loss of sensation? Yes, sensation over the upper lateral arm will be diminished. Okay, that was a lot of information, but you made it. Let's review. Give me the motor functions of the ulnar nerve. It's a wrist flexor, specifically on the ulnar side through flexor carpi ulnaris. It also flexes the last two fingers using the medial flexor digitorum profundus and the lumbricals. The ulnar nerve is exceedingly important for intrinsic muscle control in the hand, allowing for precise, coordinated movements. It adducts the thumb with adductor pollicis, which is essential for pinching and gripping. It opposes the pinky against the thumb with the hypothenar muscles, and adducts and abducts the fingers with the interossei. What is the sensory supply? You got it. Hypothenar eminence, the dorsal and palmar ulnar region of the hand, little finger, and the ulnar half of the ring finger. Okay, now let's review the median nerve. What are the motor functions? Just like the ulnar nerve, it's another wrist flexor, specifically on the side of the thumb. It flexes the thumb with the thenar muscles, and the index and middle fingers with the flexor digitorum profundus and the lumbricals. Median nerve also pronates the arm with pronator teres and pronator quadratus. What about the sensory functions? On the palmar side, it supplies the first 3½ digits and the thenar eminence. On the dorsal side, it innervates only the distal tips. Why? Because the rest is supplied by the radial nerve. And speaking of the radial nerve, tell me its motor functions. Right again. The radial nerve is the primary wrist and finger extensor. It accomplishes that function with the extensor carpi radialis muscles and the extensor indicis, extensor digitorum, and extensor pollicis. It straightens the elbow with the triceps. It also stabilizes the elbow with the brachioradialis, but elbow flexion is really accomplished by the musculocutaneous nerve. How would you carry a bowl of soup? Right, the supinator muscle turns the palm of the hand upward. What's the sensory distribution? The whole extensor surface of the arm, forearm, and the dorsal aspect of the lateral hand. The radial nerve also innervates the dorsum of the first 3½ fingers, about halfway up the finger where it meets the sensory distribution of the median nerve. Let's get back to our case. This is a 59-year-old, previously healthy woman who is receiving radiation for cancer of the left breast. She developed months of sensorimotor deficits and pain in the left arm. She has difficulty lifting her left arm overhead and making a fist with her left hand. Specifically, she has weakness in the deltoid, biceps, triceps, wrist extension, finger flexion, and thumb adduction. She had diminished biceps, triceps, and brachioradialis reflexes. And there is sensory loss on the medial side of her forearm and palm, involving the last 3 fingers. What is the most likely lesion location? Why don't we start by thinking about what nerves could be involved? The sensory loss sort of matches ulnar distribution, but only in the hand. The ulnar nerve doesn't mediate sensation in the forearm. The ulnar nerve injury could cause weakness in finger flexion and thumb adduction, but it doesn't mediate wrist extension, elbow movement, or shoulder abduction at the deltoid. And it certainly doesn't innervate any arm reflexes. Okay, what about the radial nerve? The distribution of sensory loss is wrong, I know, but remember that sensory deficits have variability and overlap, so they are not as reliable. How about motor function? Radial nerve lesions could cause wrist and elbow extension weakness. With radial nerve injury, triceps and brachioradialis reflexes can sometimes be affected. The biceps is supplied by the musculocutaneous nerve, and injury to the musculocutaneous nerve would cause sensory deficits in the lateral and not medial forearm. The deltoid is supplied by the axillary nerve. Axillary nerve injury would cause a small area of sensory loss over the deltoid muscle. What's going on? Our clinical findings don't really align with the lesion of a single peripheral nerve. The lesion may be at the level of the nerve roots or the plexus. Ulnar neuropathy often needs to be differentiated from C8 radiculopathy. Like the ulnar nerve, C8 root is also responsible for innervating finger flexion and intrinsic hand function. But C8 also contributes to the median nerve, and that nerve controls thumb and finger flexion through the flexor pollicis longus and the flexor digitorum profundus muscles. There's also a difference in the sensory innervation. Ulnar nerve supplies the last 2 fingers and the ulnar side of the hand. C8 sensory innervation follows a dermatome, which means that it also involves the medial forearm. Also, injuring a nerve root usually causes radicular pain, root pain. This pain is electric, burning, well localized, and it starts in the neck region and radiates down the arm in the distribution of a specific dermatome. What about C6 nerve root versus the median nerve? There is significant overlap in function, but the 2 major differences are wrist extension and elbow flexion. In the wrist, C6 also supplies the extensor muscles, extensor carpi radialis, which are typically innervated by the radial nerve. So median nerve injury results in weak wrist flexion, but C6 root injury will also result in weak wrist extension. C6 also supplies the radial nerve that innervates the brachioradialis muscle, and so the brachioradialis reflex may be diminished. By the way, what is the most common location of median nerve injury? Right, in the carpal tunnel. And in the carpal tunnel, the lesion would be too distal to affect any reflexes in the elbow or forearm. What about the distribution of sensory loss? Median nerve only supplies the sensation of the hand, the palm and the first 3.5 fingers, and fingertips of those fingers on the dorsal side. C6 nerve root sensory supply is dermatomal, so it also supplies the lateral forearm. C7 radiculopathy is actually the most common radiculopathy. There is significant overlap between the motor function of the radial nerve and the C7 nerve root, except when it comes to the supination of the wrist, where C6 is the dominant nerve root. Supination of the wrist is accomplished by the radial nerve innervated supinator and the musculocutaneous nerve innervated biceps. Sensation is also helpful to distinguish radial neuropathy from C7 radiculopathy. Radial nerve supplies the extensor surface of the arm and forearm and the dorsum of the hand and the first 3 fingers, but it has no sensation on the palm or the palmar aspect of those fingers. That's median nerve territory. But guess what? The middle finger is innervated by C7. I know this topic is dense and full of detail, So extend your C7 finger proudly to this topic and say with me, I will conquer your brachial plexus. You won't get the best of me. Let's analyze the pattern of weakness in our case from a nerve root standpoint. Finger flexion is C8. T1 does contribute to the ulnar and median nerves, but its sensory supply is a small portion of the medial forearm. Wrist extension, elbow extension, and the triceps reflex is C7. Elbow flexion is C6, and the biceps reflex is C5 to C6. Deltoid weakness and diminished brachioradialis reflex indicates involvement of the C5 and C6 nerve roots. Sensory loss is in the distribution of C8 and maybe C7, that middle finger. So put it all together for me. Yes, since multiple nerve roots and nerves are injured, the lesion likely involves the brachial plexus. Plexopathies often have a patchy distribution affecting several different parts of the plexus. The radiation that she received for breast cancer probably caused her painful plexopathy. The diagnosis was later confirmed by nerve conduction testing and electromyography. And speaking of plexus lesions, we have to talk about those for a minute. Let's start with upper plexus injury. Upper plexus paralysis is also known as Herb Duchenne palsy. This type of injury typically happens when there's a sudden, forceful separation between the head and shoulders. Think birth injuries or violent impacts during contact sports, like a tough tackle in American football causing the shoulder to suddenly move downward. The muscles and reflexes supplied by the C5 and C6 nerve roots will be affected. Specifically, you'll see weakness in the deltoid muscle, controlled by the axillary nerve, the biceps and brachialis muscles, controlled by the musculocutaneous nerve, and the brachioradialis muscle, controlled by the radial nerve. The good news is that C5 root doesn't really play a significant role in controlling the median or ulnar nerves. Because of that, wrist flexion and the fine muscles of the hand usually remain functional. Because of this pattern of dysfunction, the affected limb ends up in a distinctive position, internally rotated and pulled close to the body, with the forearm extended and pronated, so the palm faces outward and backward. The reason the arm is internally rotated is because external rotation of the shoulder is accomplished by the infraspinatus muscle. The suprascapular nerve that innervates it comes from the upper plexus. Sensation is usually intact, but you might notice some sensory loss around the shoulder area, specifically in the region innervated by the axillary nerve. Middle plexus lesions are pretty uncommon, so let's pretend they don't exist. Onward to lower plexus injuries. Lower plexus injury is also called Dejerine-Klumpke syndrome. Trauma can definitely cause this injury too, but don't forget about compression injuries like by a Pancoast tumor in the lung apex or even an aortic arch aneurysm. Here, the affected nerve roots are C8 and T1. Remember how with upper plexus injuries, the proximal arm is affected, but the wrist and fingers usually remain functional? Well, with the lower plexus injuries, the opposite happens. You'll see weakness in wrist and finger flexion and the intrinsic hand muscles. This happens because C8 and T1 feed into the ulnar and median nerves. Do you remember the ulnar claw? You will often see this deformity with the proximal injury of the lower brachial plexus. Sensory loss follows predictable C8 and T1 dermatomes, medial arm, medial forearm, and ulnar aspect of the hand. All right, you have survived the brachial plexus. But now we have a new challenge. This time, we got a 75-year-old man with a history of high blood pressure and diabetes. For the past 3 weeks, he's had lower back pain that shoots down the back of his left thigh and into his foot. About a week ago, he started noticing weakness in that same leg. On motor testing, the tone was normal, and there was no obvious atrophy. Knee extension and flexion are totally normal. No issues there. But when we look at the foot, that's where things get interesting. There's a foot drop, meaning the patient has trouble lifting the front of the foot. Ankle dorsiflexion strength is 3 out of 5. This patient can lift their foot against gravity, toes toward the nose, but there's no pushback when you add resistance. Plantar flexion, pointing the toes down, is also a little weak, but not as bad as dorsiflexion. So both directions are affected, but dorsiflexion is clearly weaker here. Also, both foot inversion, turning the foot inward, and eversion, turning the foot outward, are weak, but eversion is clearly worse, about 2 out of 5. And there's sensory loss too. The patient has decreased sensation along the outer part of the left leg and calf, but also on the dorsum of the foot, and to a lesser extent the sole of the left foot. When it comes to reflexes, Achilles' reflex is a little diminished on the right, but completely absent on the left. Let's see if you've been paying attention. A hypothetical patient comes in with weakness and numbness of one leg. Where could the lesion be? We think either cortex, it could be the contralateral frontoparietal cortex or the nearby white matter, the areas that control that limb. Or it could be peripheral, the roots, the plexus, or the nerves themselves. Now, could it be in the internal capsule or brainstem? Not likely, because lesions there usually hit more than just one limb. And what about the spinal cord? If half the cord were damaged, sure, you'd get weakness on the same side. But the pain and temperature loss would show up on the opposite side, thanks to the spinothalamic tract already crossing over. That's not what we're seeing here. In this case, the leg is affected and there are lower motor neuron signs, like an absent Achilles reflex. So we're leaning peripheral, most likely the lumbosacral roots, plexus, or peripheral nerves to the leg. Agreed? Now that we got that out of the way, let's talk about the innervation of the leg. Here's the abridged version of the lumbosacral plexus. We've trimmed out the rarely injured nerves. You're welcome. We're just focusing on the main players. We've got 3 big mixed nerves, femoral, obturator, and sciatic, and 1 purely sensory nerve, the lateral femoral cutaneous. Not too bad, right? Oh, and the sciatic nerve is actually 2 nerves in 1. The tibial nerve runs in the front of the sciatic bundle, and the common fibular nerve runs in the back. Without further ado, let's dive in. The femoral nerve arises from the posterior division of L2, L3, and L4 roots. The femoral nerve kicks things off by innervating the iliacus and psoas major muscles. Kicks. Get it? Because it helps you kick? These 2 muscles team up as the iliopsoas, the main flexor of the hip. They are the engine that lifts your leg when you take a step. Next in line is the sartorius. It's a long, skinny muscle that helps flex the hip and also rotates the leg outward, like if you're trying to sit cross-legged. But what is the femoral nerve's real claim to fame? Right, innervation of the rectus femoris, vastus intermedius, vastus medialis, and vastus lateralis. Together, these muscles are the quadriceps femoris group. These 4 muscles extend and stabilize the knee. Basically, they're why you don't collapse every time you stand up. Just to drive the point home, why do you need your femoral nerve? Because without it, you'd have a hard time rising from chairs, climbing stairs, or kicking a ball. Basically, anytime you need to straighten your knee or lift your leg with purpose, the femoral nerve is doing the heavy lifting. It's your go-to nerve for moving forward, literally. When it comes to sensation, the femoral nerve covers 2 key areas. It innervates the front and inner thigh through the anterior femoral cutaneous branch, and the medial lower leg all the way down to the ankle through the saphenous branch. What about the lateral part of the anterior thigh? That's the domain of the lateral femoral cutaneous nerve. It's not a branch of the femoral nerve. It's a pure sensory nerve that comes straight from the L2 and L3 nerve roots. The interesting fact about this nerve is that it can become compressed by anything tight around the hip. Tight belt, tool belts, seat belts, and even enlarged abdomen in pregnancy. The fancy term for lateral femoral cutaneous neuropathy is neuralgia paresthetica. Femoral nerve usually gets trapped at or just below the inguinal ligament. And what causes it? About 75% of the time, it's due to positioning during surgery, especially intra-abdominal, vascular, gynecological, or hip procedures. The rest are from cystic masses or tumors that press on the nerve as it passes through the pelvis. So what happens when the femoral nerve is injured? Yes, patients usually develop tingling or numbness in the front and inner thigh, sometimes extending all the way down the inner leg to the ankle, thanks to the involvement of the saphenous nerve. And if the adjacent lateral femoral cutaneous nerve is involved, sensory deficits may involve the anterolateral thigh, myalgia paresthetica. On the motor side, several important muscles take a hit. Hip flexion becomes weak because the iliacus and psoas major muscles lose their innervation. External rotation of the thigh can be mildly affected because of weakness of the sartorius muscle. But the most dramatic effect comes from quadriceps weakness, which leads to difficulty extending the knee. This is something you'll definitely notice when the patient tries to get up from a chair or walk. Patellar reflex is also served by the femoral nerve, so it may also be diminished with femoral nerve injury. 2 nerves down, 2 more to go. Next up, obturator nerve. The obturator nerve shares the same nerve roots as the femoral nerve, L2, L3, and L4. But even though they start from the same place, they head in different directions. While the femoral nerve is posterior, obturator nerve is formed from the anterior divisions. Obturator nerve primarily innervates muscles that bring the thighs together. The most accessible and the one we typically test is the adductor longus. That's the muscle you're targeting when you ask a patient to squeeze their knees together against resistance. But the real powerhouse is the adductor magnus. It's the largest and strongest of the adductors. We use it in our everyday activities like getting into a car, standing up from a low chair, walking or running, especially when changing direction or balancing on uneven ground, and sidestepping puddles. The sensory territory of the obturator nerve is just a small patch of the skin on the medial thigh. It's usually too clinically insignificant to matter. The obturator nerve is commonly injured at the pelvic brim, particularly as it passes through the obturator canal. In this narrow, bony passage, the nerve is vulnerable to injury from pelvic surgery, childbirth, and masses. And the deficits? As expected, there will be weakness of thigh adduction. All right, we left the best for last. I am the body's longest thread. From spine to toe, I boldly spread. Without my might, you'd limp or fall. I've coursed through beasts both big and small. Since ancient times, I've served them all. What am I? The sciatic nerve. It's the body's largest and longest nerve, easily over 3 feet long in most adults and thicker than a pencil. It's evolutionarily ancient, so your cats and dogs have it too. The sciatic nerve comes from the lower lumbosacral plexus. It's formed by both the anterior and posterior divisions of the L4 to S3 nerve roots. Above the knee, the sciatic nerve innervates the major muscles of the hamstring group, the long head of the biceps femoris, semitendinosus, and semimembranosus. These muscles work together to flex the knee. The hamstring muscles also assist with hip extension, thanks to their shared origin at the ischial tuberosity.
Keep the legs straight and still let me push down. Same thing here, keep the legs straight and don't let me push down.
So working together with the quadriceps, which are innervated by the femoral nerve, the hamstrings help you gently lower yourself into a chair. But the primary function of the sciatic nerve is to make everyday locomotion possible, to stand upright, maintain posture, and ultimately, to walk. Below the knee, the sciatic nerve splits into its 2 terminal branches, the tibial nerve and the common fibular nerve. Fibular is also sometimes called peroneal. The tibial nerve travels down the back of the leg, where it innervates the major muscles involved in plantar flexion of the foot, the gastrocnemius and the soleus. As it travels between those muscles, the tibial nerve also supplies the tibialis posterior. This muscle helps invert the foot, turns the sole inward, especially when the foot is plantar flexed, pointed downward. It also innervates the flexor digitorum longus, that flexes the toes, and flexor hallucis longus, which flexes the big toe. The tibial nerve controls the muscles that let you rise up onto your toes to reach the top shelf, push off the ground when you walk, or even hit the gas pedal while driving. Let's turn the leg around and take a look at the front. The anterior compartment is ruled by the other branch of the sciatic nerve, the common fibular nerve. It wraps around the head of the fibula, just below the knee, and then splits into a superficial branch, the superficial fibular nerve, and a deep branch, the deep fibular nerve. The superficial fibular nerve innervates the fibularis longus and fibularis brevis. These muscles of lateral compartment evert the foot, that is, they turn the sole outward.
For ankle eversion, you want to have the person push against your hand on the outside.
The deep fibular nerve takes care of the muscles of the anterior compartment. It innervates extensor digitorum longus and extensor hallucis longus. These muscles lift the toes towards the nose.
You want to check dorsiflexion of the ankles. So you're going to have the person extend the foot at the ankle and push on the lateral side of the foot. You can also check the extensor hallucis longus. I'm using my finger here against his toe. I'm not using my whole palm. I'm just using my finger to test the strength. I cannot overcome that.
And then there's the tibialis anterior, which dorsiflexes the foot and, wait a second, inverts the foot? But isn't inversion also the job of tibialis posterior, which is innervated by the tibial nerve? Yes and yes. Both tibialis anterior and tibialis posterior turn the foot inward. They do it during different phases of gait. Tibialis anterior inverts the foot while it's dorsiflexed as you lift your foot to take a step. Tibialis posterior inverts the foot while it's plantar flexed as you push off the ground. Here, the tibialis posterior is plantar flexing the right foot and toes and inverting the foot while it's plantar flexed, just as I'm about to push off the ground. At the same time, on the left side, the tibialis anterior is lifting the foot and toes, inverting the foot while it's dorsiflexed in preparation to take the next step. Then the cycle repeats. Here, the tibial nerve is activating the tibialis posterior to plantar flex and invert the foot, and the obturator nerve is firing up the adductor magnus and adductor longus to bring the thighs together. These two nerves are teaming up to help this person adjust his step stool, so they can grab even more library books on neuromuscular topics, of course. Now on to sensory territories. Branches of the sciatic nerve supply sensation to the lower posterolateral leg and the entire foot. Most of this territory is covered by the superficial fibular nerve, which handles the dorsum of the foot and lateral lower leg. The tibial nerve, shown here in purple, is responsible for the heel, posterior ankle, and the entire sole of the foot. The deep fibular nerve is primarily a motor nerve, but it does handle a small, very specific sensory zone, the web space between the first and second toes. Seems kind of weird, right? Why would a motor nerve supply just that tiny patch of skin? Well, that small web space happens to be at a critical pressure point during walking. It acts like a sensor, giving the brain precise, real-time feedback about how the foot interacts with the ground. This helps fine-tune balance, posture, and muscle activity, especially when walking on uneven terrain. Of course, this is just a theory, but I bet you won't forget the deep fibular nerve's sensory zone now. The sciatic nerve is frequently damaged in the gluteal region, where it passes through the sciatic notch. The sciatic notch is kind of an anatomical gateway where the nerve becomes superficial enough to be vulnerable. Injuries here are typically caused by pelvic or buttock trauma. Think pelvic fractures, hip dislocations, pelvic surgeries, or even prolonged pressure from a wallet in the back pocket. With such high sciatic nerve lesions, patients present with a flail foot. You'll see weakness in dorsiflexion, plantar flexion, inversion, and eversion of the foot and toes. Knee flexion will be affected because the hamstrings are also supplied by the sciatic nerve. The Achilles reflex will also be diminished or absent because it's mediated by the tibial nerve. Sensory loss follows the sciatic nerve's territory just as you'd expect. It involves the posterior lateral lower leg, along with both the dorsal and plantar surfaces of the foot. The next common spot of injury is behind the knee, in the popliteal fossa. Here, it's usually the tibial nerve that gets affected. The most common culprits? Things like Baker's cyst, direct trauma, nerve tumors, or the nerve getting trapped under the soleus muscle. When this happens, patients can lose the ability to plantar flex the foot and toes. Foot inversion gets weak too, and the Achilles reflex may be reduced or completely gone. Also, the intrinsic muscles of the foot are affected. I know we didn't talk about those. Basically, this injury causes big problems with walking and balance. In terms of sensation, the numbness or tingling usually shows up on the sole of the foot and along the outer edge. So, tibial nerve is kind of like the median nerve of the leg. The common fibular nerve is especially vulnerable to injury where it wraps around the head of the fibula, where it is most superficial and exposed. The deep branch is the one usually affected. That means weakness in dorsiflexing the foot and toes, so lifting the foot becomes hard, and weakness of inversion, though that may be less obvious. You also see sensory loss in the small web space between the first two toes. In a motor sense, the deep fibular nerve is like the radial nerve of the leg. The radial nerve extends the wrist and fingers, while the deep fibular nerve dorsiflexes the foot and toes. If the superficial branch is also involved, the lateral compartment muscles get weak and foot eversion suffers. And on the sensory side, there's usually numbness or tingling over the lateral lower leg and the dorsum of the foot. So the superficial fibular nerve resembles the ulnar nerve. Okay, time to pull it all together with a brief review. Give me the motor functions of the femoral nerve. Right. It's a hip flexor working through the psoas major, iliacus, and sartorius. The sartorius also helps rotate the hip outward, like when you try to cross your legs. But the femoral nerve is most known for knee extension, courtesy of the quadriceps group, rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. It also mediates the patellar reflex. What is a sensory supply? You got it! Anteromedial thigh and medial lower leg to the ankle through the saphenous nerve. Remember that sensory innervation of the lateral thigh is the job of the lateral femoral cutaneous nerve. It's a pure sensory nerve straight from L2 to L3, not part of the femoral nerve. Okay, now let's review the obturator nerve. What are the motor functions? It's all about thigh adduction, thanks to adductor longus and adductor magnus. Easy. Sensory? Just a small patch of skin on the medial thigh, which is usually not particularly obvious. Finally, the sciatic nerve. Above the knee, it innervates the hamstring muscles, semitendinosus, semimembranosus, and the long head of biceps femoris. These muscles flex the knee and assist with hip extension. Below the knee, the sciatic splits into two terminal branches, the tibial nerve and the common fibular nerve, also known as common peroneal nerve. Tibial nerve controls plantar flexion of the foot with the gastrocnemius and the soleus, and toes with the flexor digitorum longus and flexor hallucis longus. It's also responsible for inversion of the foot with tibialis posterior, and it mediates the ankle jerk. Superficial fibular nerve controls eversion with the muscles of the lateral compartment, fibularis longus and brevis. Deep fibular nerve is responsible for dorsiflexion of the foot and toes by innervating extensor digitorum longus, the tibialis anterior, and extensor hallucis longus. It also helps inversion with tibialis anterior. What's the sensory distribution? The largest sensory territory in the lower leg, covering the posterolateral lower leg and most of the dorsum of the foot, is supplied by the superficial fibular nerve. The tibial nerve handles the sole of the foot and the heel. And the deep fibular nerve supplies the web space between the first two toes. Let's get back to our case. This is a 75-year-old man with diabetes who developed sensory motor deficits in the left leg and now low back pain radiating down to the foot. The patient has preserved knee extension and flexion. The patellar reflex is intact. On motor testing, there's weakness with dorsiflexion, plantar flexion, inversion, eversion, toe extension, and toe flexion. Achilles reflex is absent. And there's diminished sensation over the lateral leg below the knee, the dorsum of the foot, and even the sole. What is the most likely lesion localization? Pause for a moment and think. First off, we can rule out femoral nerve injury because knee extension is intact and there is no sensory loss in the anteromedial thigh. Obturator nerve doesn't fit either because there is no weakness of thigh adduction. So what's left? A sciatic nerve injury, especially proximally near the sciatic notch? That's a good thought. Weak dorsiflexion and plantar flexion of the foot and toes? Check. Weak eversion and inversion? Check. Sensory loss on the posterolateral leg and both the dorsum and sole of the foot? Check. This patient also complained of back pain. That's okay. Proximal sciatic nerve injury can cause pain that radiates up, even resulting in back pain. So far, it sounds like sciatic involvement. But hang on a second. The sciatic nerve also supplies the hamstrings, which means we'd expect some weakness in knee flexion. But here, knee flexion is preserved. I guess this could still be a sciatic nerve lesion, but it's likely just above the knee, distal to the hamstring branches, but proximal to the tibial and common fibular split. But a lower sciatic lesion would more likely cause pain in the posterolateral leg, not in the back. Okay, maybe we're dealing with the tibial nerve lesion in the popliteal fossa. In that case, you'd expect weakness in plantar flexion of foot and toes, along with weak inversion. And the ankle jerk would be diminished or absent. Check, check, and check. But here's the problem. If this were just a tibial nerve injury, we'd expect dorsiflexion and eversion to be preserved, since those are controlled by the common fibular nerve. And when we examine the sensory loss, the tibial nerve mainly covers the sole of the foot and the heel. But in this case, the patient has wider sensory involvement. Okay, what about common fibular nerve injury at the fibular head? Well, the motor findings do fit weak dorsiflexion, toe extension, eversion, and inversion. And the sensory loss on the posterolateral leg and dorsum of the foot, that fits too. But here's where things don't quite add up. Foot plantar flexion and toe flexion are not mediated by the common fibular nerve. They're handled by the tibial nerve. You might also point out that the Achilles reflex and sensation on the sole of the foot are also tibial nerve territory. But I'd remind you that this patient has diabetes, so it's entirely possible that a pre-existing diabetic neuropathy is responsible for those two findings. In other words, true and unrelated. So at this point, a sciatic nerve lesion still feels like our most likely suspect. But the clinical picture doesn't line up perfectly. So what else could it be? What about nerve roots? It's a really good idea to learn how to differentiate nerve injuries from nerve root injuries. So wake up for this part. It's a last bit of important new information, I promise. Let's start by distinguishing obturator nerve injury from L2-L3 radiculopathy. The obturator nerve comes from anterior divisions of L2, L3, and L4. So naturally, there's going to be some overlap in function. Why do we have to tell them apart? Obturator nerve injury usually results from pelvic trauma, pelvic surgery, or compression by a hematoma or mass. So you'd be looking at pelvic imaging to make the diagnosis. L2, L3 radiculopathy is often caused by lumbar disease, disc herniation, foraminal stenosis, degenerative changes, so you'd need an MRI of the lumbar spine. Now, in both cases, you'll see weakness in thigh adduction. But L2, L3 radiculopathy can also impact nearby muscles, like the iliopsoas, causing hip flexion weakness, and the quadriceps, causing knee extension weakness. The patellar reflex may be reduced too. That reflex is mostly mediated by L4, but L2 and L3 contribute. What really helps you tell these lesions apart is the sensory distribution. With an obturator nerve injury, you may get a small patch of sensory loss on the inner thigh, easy to overlook. But L2 and L3 dermatomes cover a much larger area. L2 handles the anterior and lateral thigh. L3 takes care of the medial thigh and knee. And of course, radiculopathies come with radicular pain, that classic back pain that shoots down the thigh. Well, that's interesting. The sensory distribution kind of looks like the femoral nerve, and that's not a coincidence. The femoral nerve is formed from the posterior divisions of the same nerve roots, L2, L3, and L4. Except that the proximal lateral thigh is actually supplied by the lateral femoral cutaneous nerve, which is a pure sensory nerve that comes from L2 and L3 and not part of the femoral nerve. So it's the L4 nerve root injury that's most commonly confused for femoral neuropathy. Both conditions cause sartorius and quadriceps weakness. This means impaired hip flexion, lateral rotation of the thigh, and knee extension. Oh, and yes, a reduced patellar reflex. But L4 radiculopathy may also affect foot dorsiflexion and inversion, because the muscle responsible for those movements is tibialis anterior, and tibialis anterior is supplied by the deep fibular nerve, L4, L5 nerve roots. So if there is even a hint of a foot drop, think L4 root, not femoral nerve. But again, let's focus on sensation here. The L4 dermatome covers a narrow area, mostly the medial lower leg, and it spares the foot. And of course, there's that classic radicular pain starting in the back and shooting down to the medial calf. Okay, you've had the appetizers. Now it's time for the main course. We started our discussion of foot drop with L4 radiculopathy. But let's be honest, the real culprits are usually fibular nerve injury and L5 radiculopathy. The deep branch of the common fibular nerve powers the tibialis anterior, extensor hallucis longus, and extensor digitorum longus, all key players in ankle dorsiflexion, toe extension, and even a bit of foot inversion. So yes, injury to the deep fibular nerve alone can cause a classic foot drop. But don't forget the superficial fibular branch. It handles foot eversion by fibularis muscles in the lateral compartment. So far, all of this is still L5 territory. But L5 also contributes to the tibial nerve, which means it can affect plantar flexion and toe flexion too. And L5 pulls in some hip and knee action. It helps with hip abduction and internal rotation. That's your gluteus muscles. And knee flexion via the hamstrings. Now let's talk sensation. The common fibular nerve handles the lateral shin and dorsum of the foot, mostly through its superficial branch. And some of that territory is also covered by L5. But L5 also supplies the medial sole of the foot, including the great toe, which is tibial nerve territory. The sole is not touched by the fibular nerve at all. Wow. That almost sounded poetic. The sole of your soul is tibial, not fibular. Well, technically, the sole of the foot is mostly supplied by S1. So really, it's more accurate to say that the soul of your soul is sacral. Phew! The information upload is complete. You survived. Congratulations. But we're not quite done. What about our patient? He had weakness of ankle dorsiflexion and plantar flexion, toe extension and flexion, foot inversion and eversion. The Achilles reflex was absent, but the muscles at and above the knee were totally fine. He had sensory loss over the posterior lateral leg, the dorsum of the foot, and the sole. He also had some radicular back pain. So, what's injured? Exactly. L5 radiculopathy can explain all the motor findings, but the soul of your soul is sacral. So, S1 must be involved too. Oh, and S1 is also the main contributor to the ankle jerk, which is diminished here. And that's all for today. Until next time, I've been Kushi Patel for the Neurophile.